So, wait, we will just. Okay, so as you know, now the latest trend, MRCOG, MRCPI, European board, either one of them or all of them. So it is totally up to you what you want to do. So first we would like to start with MRCOG, the most well-known exam and the most oldest exam, everybody knows about it. So what are the benefits? It's a global exam, and the benefits of your career for the MRCOG and the RCOG membership. It is a gold standard qualification in obstetrics and gynecology, and it is a very big organization. I feel since my childhood, I know about MRCOG, and it is very popular all over the world, and it is considered equal to masters in medicine. So there are three parts of the exam. Part one is basic sciences. Then in part two is OB&GYN related. It's the application of the knowledge. Then once you pass part two, earlier they used to ask for assessment of training, which means that you should be, working at least work experience of more than 2 years. Then you can sit for part three. But recently, I think they have removed all these things. Or after part one, they want assessment of training, and then they will ask you if you have that 2 or 3 years of experience, then you can sit for part two. But now, after just passing part one, basic sciences exam, you can immediately go for the next part two written exam. Part two written exam, it is all application of knowledge. All the resources are available as Green Top guideline, NICE guideline, ASHRAE guidelines. So many scientific impact papers are there. You can read through them, go through them. There are talk articles, and then you are good to go for the part two exam. But there's a lot of study involved. Then once you pass your part two, there is part three exam, which is a clinical exam. You go through 14 stations, which are mostly patient-based stations. There are lay examiners there. And once you finish part three, you get the membership degree. But it is a really tough exam because I have passed all three exams. I feel MRCOG is the toughest among all. Okay, what are the benefits? One, you will get membership of the Royal College of Obstetrician Gynecologists, and really once you go and attend that ceremony, you feel that all your hard work is paid. All the people, all the members, fellows, they stand there, they clap for you, and you feel, yeah, you have achieved really something. So it's a very precious exam, very well-known exam, and really whoever passes, it's a very well-deserved exam membership. Okay, what are the benefits? You will be a professional. You have the right to use this FRCOG and MRCOG, which is awarded by the college. You can have access to the subscriptions, although there will be annual payment, but you can get this access to the subscriptions. Then you come to MRCPI. MRCPI is also equally important. After passing MRCPI, you can get GMC registration as well, and you can practice in UK after finding a job. So MRCPI, over a period of years, it has gained more popularity, and it is almost, the standing is equal as MRCOG. Although compared to MRCOG, I feel it is a bit easier exam. So it is an internationally recognized qualification, and it is accredited by the Medical Council of Ireland as the foremost knowledge-based assessment of obstetrics and gynecology in Ireland. This qualification shows potential employees that you have advanced knowledge of this specialty, and you can effectively take patient's history, perform clinical examinations, do investigations, and management plans. Once you achieve MRCPI, that means that you will enter the super specialty. So this is like before you enter in the subspecialty, you have to get a MRCPI if you're there in Ireland, or if you wish to go to Ireland. So you first pass MRCPI and then you go to the higher specialty training. Then this is recognized, as I told you, it is recognized by the GMC in the UK. So once you have passed this, you can get full registration and you are allowed to practice in UK. It is your doorway to global network of physicians. It is recognized around the world as an international benchmark of excellence in medicine, opening new opportunities of career advancement. And once you become a member, it makes a major milestone on the path to become a specialist. And you join these now 9,000 members over 90 countries around the world. It is internationally recognized qualification. This also has 3 parts actually. So if you have passed MRCOG Part 1, then you can get exemption of MRCPI Part 1. Because MRCPI Part 1 is basically medical case. All the medical questions are coming there. So it's a bit difficult to pass MRCPI Part 1. So I would say if you are planning to go for MRCPI, go for MRCOG Part 1 first, and then you get exemption for this MRCPI 1, and then you can sit for written MRCPI, that is Part 2, okay? So as it's written here that it is achieved through examination, it is aggregated by the Medical Council of the Ireland, and just wait. There are 2 parts. After passing Part 1, that is, or you get exemption from Part 1, then you go to the Part 2 written exam. It's a single paper with 100 questions. It is a single best answer, 3 hours. You do it on computer. And then once you pass this exam, you go for the Part 2 OSCE clinical exam. Then OSCE clinical exam, it has again 7 OSCE stations and 1 long case. The OSCE station are 10 minutes each station, and the clinical exam, it is for 25 minutes. It is happening now almost twice a year in Ireland and in UAE, once in Dubai and then next time in Abu Dhabi. Recently it happened in November in Dubai. So once you become a member of MRCPI, you can become an associate member of you will become a member here, and then you can get accreditation, and you it is also a tough exam. It's more of knowledge based exam. In RCOG, the difference is that there is a lot of communication skill involved, and there are other things which are also addressed. But I feel MRCPI, it is basically your knowledge. So if you have strong knowledge of the subject, you will pass, no problem. Okay, any questions so far? No questions? Everything is clear? Okay.
Yes, Dr. Uzma, it's clear.
Okay, thank you, Dr. Nida. Okay, so now the third exam. So what is the third exam? Now the new fashion, I would say, it's the European Board, European Fellowship, Board of Obstetric Gynecology. It was first introduced in 2016, and it is called EFOG, EBCOG. It has also got 2 parts, and first part is the written part, and once you pass the written part, you go for the oral part, written exam. Okay, the purpose of examination is to assess the level of competency of the candidate regarding their knowledge and judgment. Although skills and attitudes are also evaluated. This approach supports the free movement of quality assured specialists across borders within the Europe. So if you pass this exam, you can practice in Europe, but if you have to apply for a job, okay? The qualification is acceptable. This is what it means. So structure of the exam, one is part 1, that is written, then part 2 is OSCE, and once you finish both, you become a fellow of the European Board. So the written part, it is the obstetric paper and gynecology paper. One obstetric paper has 65 questions, and it has different stems, and then gynecology paper also has 65 questions. It is a 2-day exam One day you will do OBS paper, next day you will do gynae paper. Since it was online this time, so this is how it happened. One day we did OBS paper and next day we did gynae paper. They were like EMQs, 3 EMQs, and then you have to answer accordingly. The stems were given down, maybe 20 stems are there, so you have to choose the best and then finish the paper. How it is calculated the marks, it's the Angoff method, and a panel of judges will sit according to the difficulty of the question. They will, marks will be allotted to each question. So it is not same mark for each question. So the first part is a knowledge-based exam on computer test. And the second part is the OSCE. The seats are limited, so early reservation is recommended. And this is Mr. Alexandros, who you have to contact if you are willing to sit for the European board exam. Once you are successful, you will receive the award of European Fellow of Obstetric and Gynecology, which is called as EFOG, EBCOG. And it doesn't mean that you will be able to, practice, but you can find a job with this qualification in Europe. This is what they say. Who can take the exam? They must have a primary, anybody who has a primary medical degree, they are doctors. They are listed as medical practitioners in their own country. And they will be, they should have a mandatory national obstetric especially training program. That means they should have completed their training. They will send you a form. You have to fill that form. It has to be signed by your supervisors, and then they will go through it, and then they will accept if they want to, that you're eligible to sit for the written exam or no. Okay, so you will be asked to provide a good standing from the medical council wherever you are working. Candidates, they must provide evidence of their clinical experience in postgraduate training since they have graduated, and they should certify that they are not currently suspended or removed from medical practice. They must also confirm that they are not involved in any disciplinary action against them. Further information is available on the application forms on this website. So any questions so far?
So, Dr. Uzma, EBCOG will be written 2 days exam and then 1 day OSCE exam, right?
Yeah, it is like that. Till it is online, this is how it is going to work. We don't know once the COVID will go from this world, how they will change it. But at the moment, the last exam and the previous exam also, it was 2 days exam. 1 day was obstetric, next day was gynecology. Then there is a wait of like 1 month. The result comes, and then the OSCE will come. OSCE will be in 1 day.
Okay, Dr. Uzma, thank you.
Welcome. Anyone else want to ask anything?
Yeah, thank you, Dr. Uzma. For the questions that you said, the marks are different. So is it written on each section that how much the mark is, or it is not appearing?
No, Dr. Ita, nothing is appearing on the paper. It is just the difficulty of the question. As the board people who are sitting there, they decide as per difficulty of the question, they are allotting the marks. So you see, some questions are very basic ones, so they have less marks. But if the question is very difficult, like European board exam, this time I will tell you, there were few questions which were very, very basic. So they have less marks, but there were things like labor room scenarios, twin pregnancies with growth restriction, oncology questions, or fertility questions in people who are high risk. So these questions, they carry more marks, and their difficulty level is very high. So this is how they divide, but nothing is mentioned on the paper.
Okay, thank you so much.
No problem. So as we know that many people are sitting there waiting for a seat in MRCPI. They didn't get chance to sit for the OSCE. Maybe from 2018, people are waiting because 2 years there was no exam, and still they didn't get seat. I myself passed in 2018, and then I waited and waited and waited. Finally, I got a seat in November and I passed. So I think it is just a matter of time. Maybe they created this extra exam this time March, so they want to clear people who have accumulated, and there will be another exam in May. So how to utilize this time? Don't stop reading. This is the most important thing, because if you stop reading, you just get detracked. Keep revising the guidelines. Our CPI people, they expect you to answer from their guidelines. Their guidelines are almost same as RCOG, but little differences are there, like their research sensitization, their dose of NTD is different as compared to the RCOG. Then they are following some different levels of glucose control and the glucose tolerance test. That is a little different. Then the postpartum voiding dysfunction guideline is little different from the RCOG. But I think the RCOG, we have a talk, which is very old one. But the RCPI, they have a recent guideline for postpartum voiding dysfunction. So they have a different flow chart, which you have to follow. So there are just few differences among all of them. But if you are preparing for one exam, suppose you are preparing for RCOG, you read the green top guidelines. And once I started my journey of MRCOG, people scared me so much. They said, oh, you have to read everything, those 60, 70 page guidelines. How as a human being, you will remember 60, 70 page guidelines? And there are so many guidelines. And apart from guidelines, you have to read the ESHRE guideline, the scientific impact paper, the TOG articles, NICE guidelines. So, you know, you cannot retain all this. So once you are reading the green top guidelines, just read the executive summary. If you know your executive summary by heart, I'm sure you will pass the exam. Then even in the TOG articles, there are certain tables. So you have to memorize those tables. If you know those tables, you will pass the exam. The flow charts, make a folder of the flow charts and the appendixes which are covering in these guidelines. If you remember them, you have a lot of knowledge that means. Then, just keep reading, don't stop, make flashcards for yourself of each topic, and you're good to go. Any questions? Dr. Nida, I think you also didn't get seat this time. Are you here, Dr. Nida?
Yes, Dr. Uzma, I didn't get seat this time. I passed in March 2019.
Okay. So I would say, Dr. Nida, that just keep studying. Don't stop. Keep revising 1 or 2 guidelines every day. Because if you leave now, then it is very easy to, forget everything. So just keep going through the books, small flashcards, and because March is now, we are in Feb. After 2 months, May exam will come, and then if you find a seat, you will rush and you will get panic. Like many people who were just sitting and they found a seat, they got selected. Now they are very panicked what to do. So instead of going till the last day, just keep yourself prepared. So that once exam is announced, you just need to revise. Because once you are revising, it's very difficult to remember everything. So unless you have a solid background knowledge, then only you can, I feel the month before exam is not for preparing from the scratch. It is for revision. So keep reading and inshallah, you will do it.
Yes, sure, Dr. Uzma, thank you. And we will keep asking for your guidance at each and every step. And I hope we will do it, inshallah.
Inshallah, inshallah. All of you will do it. It's not, everything is doable. Believe you me that I also did all these exams. I relocated from Pakistan to UAE like 13 years ago. I did all these exams in UAE, one after the other. And it was, I'm working full time. I have a family. Still, I managed to pass all of them. So everybody can do it. These are all doable things. Just you need to stay focused and God will help you. Or anyone want to ask any question regarding these exams?
Dr. Uzma, can you just brief about EBCOG preparation also?
Okay, EBCOG preparation, as I said, the preparation for all the 3 exams is same with very minute differences. Like EBCOG, what is different? They have very few extra guidelines which they are following. Like ovulation induction is different for them. They use letrozole instead of Clomid as first-line drug. So this is a very small difference. And endometriosis, anyways, everybody's reading from ASHRAE guideline, so you follow that one from European guidelines. And they have their oncology part. It is a freely available application. Everybody can download on their mobiles. It is called ESGO, ESGO. So all the oncology, endometrial cancer, cervical cancer, ovarian cancer, whatever they follow, it is mentioned there. So you can start reading from there. Rest of the things are same as RCOG. And if you are well prepared for RCOG, you can pass European board also. The exam was a bit difficult because once there was no, as such guidance for the exam, and the exam was online once I did it. And even the book, which is just came out, I think 2 months or 3 months before, it was also not available. So people didn't have idea what questions will come. So most of the people prepared from whatever you need to prepare for RCOG, MRCOG, and MRCPI. And it was enough, I think. But they asked many more questions from oncology and from infertility. So just focus on oncology and infertility more. And there were questions like intrapartum questions and twin pregnancies with growth restrictions, one baby, other baby dies, things like that. So little higher level of knowledge is required for the written exam. But the OSCE exam was very easy one, I feel. It was the easiest among all. So if you pass this one and you have proper guidance, you can all pass this European board, no problem.
Thank you so much, Dr. Uzma.
No problem. Anybody want to ask anything, or we'll go to our session for today? I think we will go for our station because there is no more question here. Dr. Dhaval, you are here?
Yes, I am Dr. Uzma.
How are you, doctor?
I'm doing well, thank you.
Can we start the session with you? Thank you so much for coming forward and taking the task.
Thank you.
Okay, doctor, here is your task. Okay. So before we start, I will just tell you it will be an evolving scenario. Dr. Dhaval, you will do the first part of the task. And if anyone among the attendees is interested, they can take the second part, because we don't have our candidate is busy in her duties, so she couldn't, perform today. So let's start with the first part, and then if anyone else want to do the second part, we will ask them to perform. Okay. All right, Dr. Dhaval, this is the scenario. So you are called to see a patient in emergency department. She is Mrs. Jonah Lynn, 32 years old. She's gravida 3, para 2, 32 weeks pregnant. She came with vaginal bleeding. So you are expected to take her history and formulate a management plan for her. Your time starts now, or you want to gather yourself?
So actually, this is the first time I'm taking an OSCE exam. So my question is that, do I answer as though I am talking to the patient, or do I answer in third person?
No, I am your patient, you are talking to me. Just you are seeing a patient, this is your patient, and you are taking history from me, and you will tell me the management plan, okay?
Okay. So depending on the time of the day, good morning or good afternoon, Mrs. Jolin. I'm the doctor in the labor ward today. And I believe you are in your third pregnancy, 32 weeks pregnant, and you've presented with vaginal bleeding. I would like to ask
Yes.
you to get your history before I proceed with examining you. Will you be comfortable in? I'm sorry?
Sure, doctor. Yes, doctor.
Okay. Can I confirm your age?
I'm 32 years old.
Okay. And this is your third pregnancy?
Yes, doctor. This is my third pregnancy.
And what about your first two pregnancies?
My first two pregnancies were normal, doctor. I delivered normally. My last child is 4 years old, and everything is fine. And till now, everything also was fine. Certainly, I don't know what happened. I started to have bleeding and some pain. I'm very anxious. Is everything okay? Why I'm bleeding?
Okay. First of all, you don't need to worry so much. We are here to take care of you. And what I want to know is, when did you start bleeding? How many hours ago did you start bleeding?
Actually, doctor, it was a busy day for me. So I was having some pain in my tummy. I just ignored it. But maybe 2 hours ago, I saw little blood on my panty. And again, after 2 hours, little more blood came. So I thought I should go to the emergency and check what is going on.
Right. You've done the right thing. So can I ask you whether you are able to feel your baby moving in the tummy?
Yes, doctor, my baby is moving.
Can you
Why?
tell me? No, this is just a routine part of our history. That's why I'm asking. And can you tell me, is there pain, and where is the pain?
Pain is not too much, but it is all over my tummy. It's like small cramps which comes and goes.
Okay. Now, would you mind if I asked you a few intruding questions?
No problem. It's fine, doctor.
Okay. Has there been, have you been smoking or consuming alcohol or recreational drugs?
No, doctor. I used to smoke and drink before my pregnancy, but as soon as I know that I'm pregnant, I stopped everything.
Okay, that's great. And have you had any fall or any history of trauma in the past few days, or maybe today or yesterday?
No, I was just overworked at my office. That's it. No trauma, nothing, doctor.
Have you been regular with your antenatal visits?
Yes, doctor. I'm following with my midwife, and everything is fine.
Everything has been fine. As I see from your previous scans, that all your reports seem to be normal. So do you mind examine you and try to figure out what could be the cause of your bleeding?
Yes, sure, doctor.
Okay. So I'll first examine you. I will check your blood pressure and pulse. And once that is done, examine you on your tummy and try to hear the baby's heartbeats.
Okay, doctor. Just now, before you came, your nurse came and she did my CTG, you call it, and she said baby heart is good.
Okay.
You can have a look at the CTG, doctor.
Yeah, I'll take a look at the CTG. And in the meanwhile, I would also like to, I have seen in your previous sonographies that the placenta is located in a normal position. That means that the placenta is not, placenta what provides nutrition to the baby is not present in the lower side of your uterus. It is present where it should be normally present. So we are safe if we conduct an internal vaginal examination. Will it be okay if I conduct a vaginal examination on you?
Doctor, you are the doctor, you decide. Whatever you say, I'm ready to do it.
Okay. Okay. And Dr. Uzma, now how do I proceed? I mean,
Okay. Okay, see, Dr. Dhaval, you are seeing this patient, you took your history. First, you have to do a complete history because you just asked me about my previous deliveries. What about any medical problems I'm having, any surgeries I had in my past, any allergies, any drugs? So you have to follow your history template. Okay, so you complete your history template first, and then you said that, okay, you will examine me in the presence of chaperone with my consent. That is good. After examination, you will formulate a management plan for me. What is your management plan for me? Like you want to do some investigation, you want to admit me, you want to send me home, what you want to do?
Depending on the examination and the amount of bleeding, if the amount of bleeding is mild and there is it has stopped since you have arrived in the hospital, we can reassure the patient and send the patient home and ask her to follow up with the midwife or come back to the emergency if there is a repeat episode. However, if the bleeding is moderate to severe, it definitely warrants an admission and investigations. Routine investigations like a complete blood count. If the patient is Rh negative, a Cleaho-Bethke test, replacement of fluids, and assessment of the fetal heart rate periodically.
Okay. And now, okay, on examination, there is mild bleeding. On CTG, the fetal heart trace is reactive, but you see small like irritability is noticed. So what would you like to do with the patient now?
I will definitely like to admit the patient, and
okay.
One is for the maternal interest to see whether the bleeding is progressive, whether it stops, increases or decreases. The second is for the fetal well-being, to monitor the fetus regularly. And if the irritability of the uterus over the period of time increases, then my suspicion of a placental abruption is more. The first investigation that I would like to do on this patient after resuscitation and sending baseline investigations is to get an ultrasound done to confirm placental localization and if there is a retroplacental clot that is observed.
Okay, and you have the investigations. There is no placental abruption. Baby is doing fine. Placenta is fundal, and you have admitted the patient, right?
Yes, I have.
So after investigation, what would you like to do? How you will manage? You want to give anything to the patient?
Yes, I will give a single dose of a corticosteroid to the patient for fetal lung maturity. And I will, if the placenta is fundal and there is no evidence of a retroplacental clot, and if the patient has stopped bleeding, then I will reassure the patient and discharge her.
Okay, so from now onwards, you have discharged the patient. Can I ask you why you said single dose of steroid you will give to the patient?
What I meant by a single dose is a single course of steroids.
Yeah, single course. That means either dexamethasone, 4 injections, or betamethasone, 2 injections, right?
Yes.
Okay, suppose this patient, she's 32 weeks right now, and this patient, the bleeding stopped, but the contractions are there. So what would you like to do?
I will first not discharge such a patient who is still contracting, although the bleeding has stopped. And only after confirming that it is not on USG, it is not a case of an abruption, I would like to offer her tocolysis only till the time the steroid cover kicks in.
Okay, you have given her tocolysis, have given her steroids, still the contractions are there, and she's progressing in labor. She's 32 weeks. Anything else you want to do for her?
Intrapartum magnesium sulfate for neuroprotection can be given at the dose of 4 milligram loading dose and 4 grams a loading dose and 1 gram per hour as an infusion. it can be offered. It is of benefit in preterm pregnancies.
Okay, very good. Okay, so overall, once a patient comes, you take her complete history. You have to make sure that you're following the history template, obstetric history template. Okay, cover all the points. Finish your history taking, examine the patient. Then you tell her that what all blood investigations you need to do. Any patient who is coming with an episode of bleeding, you should admit the patient. Okay, and then after admission, you will do all the investigation. Maybe the patient will need corticosteroids, maybe the patient needs glycolysis, maybe patient needs magnesium sulfate for neuroprotection because she might deliver. Okay, so this patient, thank you, Dr. Dhaval. I will get back to your feedback later, and we will come to antipartum hemorrhage and abruption placenta and placenta previa later. I want to continue with the scenario. Anybody else among the attendees would like to take the case from here? Who else there? We have so many people who want to take the station. No one? Hello. We have 20 participants. Come on,
Ma'am,
guys.
Sally ma'am, Sally ma'am,
Who's
Manikam
this?
ma'am,
Sorry.
Manikam ma'am.
1 minute, Dr. Manikam. 1 second. Let me see who else is here. Okay. All right. Anyone else? Otherwise, we will take Dr. Manikam. Okay, no one wants to participate. Oh my God. Don't
Hello?
be shy. Okay, yes.
Hello,
So,
can I participate? Hello?
who is this one? Sorry.
Dr. Sabah.
Yes, Dr. Sama. Okay, Dr. Manikam, is it okay if I ask Dr. Sama? Last time also you presented. Is that fine
Okay,
with
ma'am.
you?
Okay, ma'am. No problem, ma'am.
Oh, thank you so much, Dr. Manikam. Welcome, Dr. Sama. Thank you for coming forward and taking the session. Okay. So now this is your task. Okay, here. So this patient who Dr. Dhaval saw in the emergency, she was fine and she was discharged after 2 days. This patient comes in labor now, okay? And you are called to see this patient in labor room. She progressed to full dilatation. Her vaginal examination that she is fully dilated. Her vertex is at 0 station. Membranes are ruptured. Clear liquor is draining. The midwife calls you because she is not happy with her CTG. Okay?
Okay.
Okay. So now you are in the labor room and I am your patient. Okay?
Okay.
Yes.
I will take history or I know that this patient, or I will take history like I don't know anything about the patient.
No, you know this much only, that she was gravida 3, para 2. Now she's 38 weeks. She has previous 2 normal deliveries. She had this 1 episode of antipartum hemorrhage at 32 weeks, and she was managed conservatively, discharged home. She was fine after that. Now she came in natural labor, and she's fully dilated, but her CTG is not good. There is no previous significant history. Okay, so now I am the patient. And midwife is with me, and you are here to see me. Now you start from here.
Okay. Hello, I'm Dr. Samah, one of the doctors in the duty in the labor ward today. May you confirm your name and age, please?
Yes, doctor. I am Jonalyn. I am not feeling well. I don't know.
I'm really sorry. Do you have pain right now?
Yes, doctor. A lot of pain is there.
So do you receive any type of analgesia, or can I ask one of the staff nurse to come and give you some injection?
I think yes, doctor, because till now I was thinking I will go for everything natural, but really I cannot tolerate this anymore. It's too much.
Okay. I will ask one of the staff nurse now to come and give you some injection. So how you
Thank
are
you,
feeling right now?
as I told you, too much pain, and I'm tired, I'm exhausted.
Okay, okay. Can I take some history from you, some question, to ask you some question?
Yes, doctor.
Okay, okay. So as I know from your notes that this is your third pregnancy and you are now 38 weeks, is it right?
Yes, doctor.
The midwife called me because you have some, she has some concern about the baby heartbeat. So I'd like to ask you, since when this pain started?
Doctor, I started to have pain last night, and initially I stayed at home. But you know, maybe you went through my nose. I had this bleeding at 32 weeks, so they told me to follow in the consultant-led unit. So that's why I came to the hospital, and everything was fine. And I thought I'm good, so I will not take any painkillers, and I will go for a natural birth. So just like that, then my midwife, she broke my water, and she said like 1 hour ago, I'm fully, and I need to push. I'm trying to push, but I don't know what is going wrong. She's saying something is wrong with my baby's heart. Can you tell me what is going on, doctor?
Yeah, actually, you are doing well. You are really doing well. Can I continue now?
Yes, doctor.
Yeah. Actually, the baby heartbeat coming down in the trace, and your womb is opened fully. That's why we need to give you some help by using some instrument to fasten your delivery, because I can see that you are already exhausted, and the baby start to be also distressed. So for how long you are pushing right now?
1 hour, 1 hour. I'm pushing, doctor.
So I can see also in your notes that you are having bleeding at 32 weeks. So since 32 weeks till now, do you have a good baby movement?
Everything was absolutely fine, doctor, after this episode of bleeding. And I don't know why my baby heart is not doing good now.
Okay, okay. And do you have any allergies?
No,
Okay. Any surgeries before?
no, doctor, no surgeries.
Okay. And do you have any medical history of concern?
No, doctor, I'm otherwise fit and well.
Very good. And any family history of concern like diabetes, hypertension?
Like, yeah, my both parents are diabetic. Other than that, everything is okay.
And how they are doing right now?
They're well controlled, no problem.
Okay, good to hear that. Okay, and I can understand that you stopped smoking during pregnancy. Is it right?
Yes, doctor. People told me that it's not good to smoke while you're pregnant, so I stopped. I want a healthy baby.
Yeah, that's good to hear also. And I can see that you are not drinking or taking any recreational drugs. Is it right?
Yes, doctor.
Okay. Thank you for this information. Do you want to add any further information that you think it's important to me?
No, doctor, I just want to know that what you will do now for my baby. You can see the CTG, doctor. Is it really bad?
Yeah, I can see in the trace of the baby heart that the baby heart, it is like what? This one or this one? Okay, that's the baby heart is how to explain this decreased variability. So like it is little bit distressed with contraction. So and you are also opened your womb. So we need to help you by applying some instrument. How you feel about that?
Yes, doctor, instrument. Okay, can you tell me what will happen if you will put instrument? Just, I want to show you, this is her initial CTG. Now this is the second CTG, okay? And this is the current CTG, okay?
Okay.
All right.
So
Yes, doctor, tell me what you would do with me.
Yeah. We need to help you. We have actually two types of instruments. What it's called the ventouse cup or the forceps or spoon. It's like a metal spoon. As your, I need to examine you in the presence of a chaperone after your permission to check the position of the baby head and how it's rotated, how it's lying inside your vagina, inside your pelvis, and accordingly we will do one of them. However, as your womb is opened, we will try to do the ventouse cup. How you feel about that?
Doctor, I don't know what is ventouse cup. You are talking of some metal you will put in my vagina, metal? I don't understand all these things,
Yeah,
doctor. What are you saying? It will not harm my baby?
Actually, a ventouse cup, it is a small plastic cup. It's creating some pressure, helping with you. It's like a teamwork with your push, and I will pull from down the baby head to deliver it. It can carry some risk for the baby, but it's considered a safe procedure. This some side effects like appearance of some swelling on the baby head. It's like a chignon. Sometimes causing this chignon, sometimes causing also some bleeding under the skin of the head. But it's a rare complication and it's not happening every now and then. However, let me reassure you that after delivery of the baby, the baby doctor will take him and examine him and also update you by the condition of your baby. Am I clear to you?
Yes, doctor, you are very clear.
Yeah.
Okay, doctor, come now. We stop for the instrumentation over here. Now the patient part is finished. Now you are with the examiner, okay? So the patient you were talking to right now, doctor tried vacuum forceps for her because it was a high head, but it was failed forceps, and patient was taken to OT for emergency cesarean section. So this is now a second stage cesarean section, okay? So now tell me how you will perform the second stage cesarean section.
Second stage cesarean section, it's considered like a quite difficult cesarean section because the head, it will be like impacted inside the pelvis. So first of all, I'd like to inform my consultant to come and attend the delivery. I will proceed I will refer the patient urgently to the theater. We will discuss with her, of course, the type of the, and I will let her sign the consent, discuss with her the possible complication for her and her baby for the cesarean, and take consent, and also discuss the anesthesia. Either it will be spinal or general anesthesia. Then in the theater, I will first we will sterilize the patient. We will do hand sterilization, scrubbing, and sterilize the skin. Then opening the skin by Golcohen incision, which is 3 centimeter below the horizontal line connecting the anterior superior iliac spine. Then excising the subcutaneous fascia, taking care because of the inferior epigastric artery to not cause any hematomas. Then separating the rectus muscle, and once we reach the peritoneal cavity, we will open the peritoneum high to avoid any injury to the bowels. Then we will open the uterus. We will take care because the lower part, it will be very thin, and there is a risk of injury to the baby head by 2%. Then we will try to disimpact the impacted head during delivery. Either to help from one assistant to do pushing from down below, or to insert a fetal below, which is injected by about 160 cc normal saline to disimpact the head, or by trying the backward hand maneuver, which is delivering of the baby shoulders, then the body, then it will be the head at last. After that, we will close the abdomen in layer. We will first try to give the patient, of course, oxytocin 10 milligram IV after delivering the placenta, and ensure that the placenta and the membrane delivered complete, and checking if there is any extension, because it's quite a high risk cesarean, and there may be extension or hematomas. And after ensure that we are secure the bleeding, we will better to suture the uterus intra-abdominal. We will use 2 stitches or 2 layers enclosing the uterine wall. Then after that, we will close the rectus sheath and the subcutaneous fat. If it is more than 2 centimeter, then the skin by subcuticular method.
Okay, very well done, Dr. Samir. Anything else you want to add once you're delivering the baby, what you would like to do?
Yeah, the baby will be handled to the baby doctor immediately after delivery. He will check the baby by checking the cord blood gas. Then after the delivery, we will inform the mother and debrief the mother about everything happened during the cesarean and the condition of the baby, and document everything. Then we will start for her the post-operative care, like giving her analgesics, assess the risk of venous thromboembolism, giving her antibiotic if indicated, taking catheter care, do enhanced recovery program, remove the catheter as soon as possible, allow her to ambulate, to have feeding, oral feeding as soon as possible, and just it.
Okay. Thank you very much, Dr. Samir. Just I want to ask you one more thing, that once you saw that CTG is the first trace I showed you, this trace, this one. So if you see a trace like this in labor room, what are the initial resuscitation measures you will do for a patient?
Yeah, first of all, we need to do conservative measures like changing the patient position, left lateral position, give her IV fluid, and then ask her to be examined after her permission in the presence of a chaperone to do fetal scalp stimulation. This one to try to stimulate the baby by moving the head. It will we will see the acceleration. And of course, we will inform our consultant because there is decreased beat-to-beat variability, and elongate the CTG, because after 50 minutes of decreased variability, it will be like a pathological CTG. So we will, if also the cervix is open than more than 3 centimeter and it is pathological CTG, this decreased beat-to-beat variability more than 50 minutes, so we need to do fetal blood sampling.
Okay, and what are the normal levels of fetal, this one, pH?
The pH, it is from the normal, it is from 7.25 up to 7.2. I'm not remembering that much. 7.21.
No problem. No problem. You have done very well so far, doctor. Thank you so much for participating. Now we will move to the third part of the scenario. Dr. Vidya, we will go through each part later at the end. Okay. Thank you so much, Dr. Samir. Dr. Vidya, you are here?
Thank you, doctor.
Yes, Dr. Uzma, am I audible?
Yeah, you are very much audible. Okay. So this patient now, we did cesarean for her. Okay. Now you are thinking, this is like, you just changed the scenario. This patient delivered normally with the vacuum. Okay. And she's in the labor room, and you're called to see the patient post-delivery as she's feeling dizzy and her blood pressure is dropping. Okay.
Okay.
So now you will not be asking anything from the patient. You will be
Okay.
answering questions. You will be talking to the consultant. Okay.
Okay. Okay, can I start?
Yeah, sure.
Okay. As I have been called to the labor room, I want to know the patient's brief history. Along with that, I want to know about the present situation. Can I get the details about the patient?
Yes, this patient was gravida 3, para 2, now para 3. She had vacuum delivery because of fetal distress 1 hour ago. And she felt dizzy now. We checked her blood pressure, and the blood pressure is 90/50, and she looks unwell and looks pale.
Okay, and as it is, I want to examine the patient. I want to check as she has delivered. I want to check her pulse rate. I want to check her saturation. I want to check her per abdominal examination as she has delivered post vacuum. I want to check for her whether the uterus is well contracted and how is the bleeding. Local examination, and is there any local swelling or hematoma also? I want to check post vacuum delivery. Can I get any findings?
Yes, her blood pressure, as I told you, it is 90/50 and it is dropping. Already it is reaching up to 80/40. Pulse is 110. Saturation is 98%. Her respiratory rate is 20. And the uterus is not very well contracted, and she has excessive bleeding from down.
Okay, at this time, I want to start the management immediately, including calling for help. And as the patient, I'm suspecting she is having a postpartum hemorrhage, and she is having excessive bleeding. So I'll be doing communication and also doing the resuscitation of the patient together. Along with, I will be monitoring her and sending for investigation together while trying to control the bleeding. And At this time, while calling for help, I want to inform my senior consultant and also will be calling the senior midwife and also the hematologist. I will be informing in case if she requires any blood, and also the laboratory for the investigation to be sent, and inform also the porters to be arranged, and inform OT and also anesthetist if in case we need to take her up. Along with that, I'll assess her airway, breathing, and circulation. I will check her conscious level as she's feeling already dizzy. If I'm able to communicate with her, I can tell her that she's having a situation that she's having a little bleeding and not to worry, and she'll be seeing a lot of people inside the room, and her partner and her relatives also will be briefed, and will be if as her BP is falling, I'll be starting with giving her insert two large IV cannula and start with the IV fluids. Starting with the before starting the IV fluid, I'll draw blood for the investigation for the cross matching, at least for the 4 units of blood, and group specific blood, and also the complete blood count, RFT, and LFTs, and electrolytes. And this thing, and also for the coagulation profile, I'll be sending the blood, and we'll be starting with the fluids with 2 liters of crystalloid and also 1.5 liters of the colloid solution immediately to be pushed for the patient. And along with that, we'll be giving her oxygen by 10 to 15 liter per minute, and we'll insert a catheter to drain the urine. And also we'll be trying to keep the patient warm as her BP is falling, and she shouldn't go for hypothermia. Along with that, we'll be trying to do a bimanual examination and try to find out the reason, whether it's the bleeding is because of tone, whether because of ethnicity or because of a trauma, as she has undergone vacuum delivery, whether is there any vaginal hematoma or the perineal tear, whether there is bleeding from that, or whether she had any previous problems with the coagulation, that also I want to find out, whether it's because of a thrombin factors or if it's because of any retained tissue. I want to check even the placenta, whether it's completely complete or not. And even I want to take a history whether the active management of the 3rd stage of labor has been done or not. If it's done, whether it's if the 10 units of oxytocin is given, I can additionally give another. I'll first rule out the allergy for her drugs if she is not having any drug allergy or the hypertension and also the asthma, as I will be giving this thing. Initially, 5 units of slow IV oxytocin will be given. If she doesn't have any hypertension, can go ahead with ergometrin injections, slow IV or IM 0.5 mg, and can give her carboprost IM injection 250 microgram of every 15 minutes up to 8 doses can be given if she doesn't have any asthma or any other issues with cardiac or any allergy to the drug, but can make up a decision even after a 3rd dose of carboprost. If the bleeding is not controlled, may need her to shift to the OT for the further management. And can consider giving tranexamic acid 1 gram also. Well, okay. Yes.
All right. So you have done this one. You have given her all the uterotonics, but she is still bleeding. So you shift her to operation theater. So what do you do in OT?
Before shifting to the OT, I'll be taking an informed consent from the patient and also from her partner, and we'll be shifting her to the OT. We'll be following a WH safe surgery checklist, and before that, I want to examine locally preferably under as her comparing to her vitals, she can be taken under general anesthesia. And I will be looking for the if there is any extension of the tear, I want to suture that. And if still uterine atonicity is there and the placenta is complete, we'll be trying to give a balloon tamponade. And if the bleeding is not controlled, I'll be going ahead with the this thing, brace suturing will be done. And still the bleeding is not controlling, I'll go for the stepwise devascularization, first with the uterine artery ligation, then unilateral iliac artery ligation, then bilateral. And can even try for a aortic compression also. If but I need my consultant in the unit during the surgery at that time. And if the intervention radiologist is available, can go ahead with the uterine artery embolization also. And if it's not happening, and considering as it's her third pregnancy, and considering her wishes, still, if in view of the patient, can go ahead with the hysterectomy if all the steps are failed without delaying.
Okay. So this patient, you put balloon tamponade for her, and she's fine. Shifted to now. What you will do?
If her this thing is bleeding is controlled, I want her to shift to the high dependency unit, where she will be monitored with the Muse chart, and will be monitoring her temperature and pulse, BP, everything, and intake output chart also. And her blood investigation will be repeated. Depending on that, if she requires, if the platelet is less than 50,000, can transfer the platelets. If there is a problem with the fibrinogen level less than 1.5, we can transfer the even the fresh frozen plasma, and also the cryoprecipitate for the patient. And they will be monitored. She will be monitored when the patient is fine. As it's a case of a major PPH, this needs an incident reporting. Coming to the clinical governance part, it requires an incident reporting, and I'll be filling a DATIX form, and we'll be debriefing the patient about what has happened and what are the steps were taken. And we'll debrief the team also what could have been done to prevent such situation in the future, or what could have been done to prevent at that time. And if these things have happened, I want to do an also inform the risk management team to find out the root cause analysis. We'll be doing a duty of conduct to the patient in the future, and also involve the patient and inform the steps what are the taken by the risk management team.
Anything else?
That much I can remember, Dr. Uzma.
No, you have done very well, Dr. Vidya. Only documentation you did not mention. So you have to document everything, okay? Whatever you have done. So you have covered everything, whatever is required in a postpartum hemorrhage. Very well done, Dr. Vidya. So let's start now from the beginning. So our patient came initially with antipartum hemorrhage, okay? So Dr. Dawal, you are here with us. Doctor? I don't know if he's here or no.
Yes,
Anyways,
yes, I am.
yeah, you are here. Okay, so whenever a patient is coming with antipartum hemorrhage, so what is antipartum hemorrhage? Any vaginal blood loss of more than 15 ml after 20 weeks of gestation. It's called an antipartum hemorrhage. It can happen in 5% of the pregnancies, and it accounts for about 20 to 25% of perinatal mortality. So what are the causes? So whenever you are seeing a patient with antipartum hemorrhage, what should come in your mind that this can be a differential diagnosis, a cause of her bleeding? It can be placenta previa in 20% cases. 30% cases, it can be abruption. And there will be unknown or different factors like vasa previa, marginal sinus bleeding, rupture uterus, or local causes. Local causes can be, they are 5% only, and they can be cervicitis, any erosion or polyp, a cervical cancer, vaginal or vulval varicosities, any infection, any foreign body in the vagina, any infection, Sometimes patient will be in labor, so it will be a show, degenerating fibroid or a non-genital tract bleeding. So non-genital tract bleeding, what should come in your mind? Maybe she's bleeding from urine, she's having some urinary tract infection or some stone, or she has a GI bleed, she's bleeding from rectum, but she feels this is coming from her vagina. So you have to keep all these things in your mind once you're going to see any patient with antepartum hemorrhage. So remember to exclude all these things once you are taking history from the patient. Okay, doctor?
Okay.
All right. So it can be a painful bleeding. So once it is a painful bleeding, you go for more abruption. If it's a painless bleeding, your mind is more towards the placenta previa, right? So as per severity of bleeding, it can be mild, moderate, or severe. Mild means that less than 15% of the circulatory volume is affected. Vital signs will be stable. There will be no hypotension, and the output will be normal. Moderate means about 30% of the volume, circulatory volume is affected. So there will be changes in blood pressure or pulse with the posture or without posture. Patient may feel thirsty, dyspneic, and other things will start. And if it is a major bleeding, then patient can be in shock. There may be fetal distress or fetal death, and there will be oliguria. So what is the initial management? Patient who is coming with bleeding, admit her, okay? So once you admit, then you do a history, detailed history, you examine the patient, you observe her vital signs. Do not do a vaginal examination unless you are sure of the location of the placenta, okay? So you put an IV access, you start resuscitation, send the blood for clotting screen, complete blood count, cross match. And if she is RH negative, you have to perform a clear test, start CTG, do an ultrasound for the placental localization. And if the placenta is not Previa, then you can perform a speculum examination. And according to her rhesus status, you will do you will give her NTD injection. Okay, so once somebody asks you that how you will manage a patient with antepartum hemorrhage, these all things you will speak. Okay? Okay, Dr. Dhawan?
Yes, okay.
All right. So as I told, the ultrasound may show placenta previa, retroplacental hematoma. It will tell you about fetal viability, size of the fetus, what about the amniotic fluid. CTG, you will see if it is normal, it is fetal tachycardia, if the hemorrhage is severe, you might need to do renal function, liver function, all these tests needs to be done. So if it is a painful bleeding, you suspect abruption. So abruption is premature separation of a normally situated placenta, right? So if the bleeding starts into the deciduorbisalis, it impairs the placental function, and it can affect about 1.5% of pregnancies, and the perinatal mortality associated with placental abruption is about 10%. There are different types of placental abruption. It can be concealed, it can be revealed, or it can be mixed. Okay, either you will see the blood or there is no bleeding, but there is pain. So that will be a concealed type. Complications of abruption, patient can go into DIC, the baby can die, there can be a hypovolemic shock for the patient, and there can be fetal-maternal hemorrhage. Okay, so if the patient is RH negative, so sensitization of the mother can occur. There can be amniotic fluid embolism. These patients are more likely to go for postpartum hemorrhage and perfural sepsis, Sheehan syndrome, and there can be maternal death as well. So what are the complications for the baby? What can happen to the baby? Baby can be born prematurely. If the baby is not born, then maybe baby will have growth restriction. There can be hypoxic ischemic encephalopathy. There can be cerebral palsy. And if it is heavy bleeding, the baby can die also. So anybody who comes with antepartum hemorrhage, you will consider all these things if the pregnancy is continued, and you will follow the baby for all these possible complications. So what are the predisposing factors for abruption? Hypertension, Any trauma, very nice you asked me about any trauma to the abdomen. Any procedure like external cephalic version or a manual vacuum aspiration, like miscarriages they are doing, then suddenly if the patient is a case of polyhydramnios and she ruptured her membranes, sudden decompensation can occur, which will lead to placental abruption and bleeding. Any pre-labor or preterm rupture of membranes, any substance abuse like cocaine, amphetamine, any previous history of abruption, it is very strongly related with the abruption again. Then antiphospholipid syndrome and multiple pregnancies. So this we already did, that it can be mild. Mild means less than 200 ml of blood loss. The uterus is soft and the CTG is normal. If it is more than 200, we call it as moderate abruption. In this case, the uterus is tense or tender and the CTG is abnormal. Then these are just initial either painful bleeding, painless bleeding. How you diagnose? It is a clinical diagnosis, and then you confirm it with the help of examination and investigation. So all abruptions cannot be ruled out with ultrasound. So you should use your clinical management also. And as I said, you will admit the patient, history examination. As per the blood loss, you will do the resuscitation of the patient, assess the fetal well-being, and do the scan. So this we already talked about. And the second cause can be placenta previa. Where is placenta previa? Once it is implanted on the lower part of the uterus, it can happen in 1% of the pregnancies. It is associated with the mortality of 3%. A major problem is the preterm delivery. And most of the placenta previas are diagnosed at 18 weeks, but they move as the pregnancy advances. The placenta, it moves to the fundus. So there are 4 degrees of placenta previa. Low lying, the edge is not near the internal os, but you can palpate if you pass your finger through the cervix. Marginal, partial, and total. Now they just say it is a low lying or not low lying. 2 centimeters, they keep like it should be. If it's more than 2 centimeters away from the internal os, it is not a placenta previa. This is the latest one. So what are the things associated that can cause placenta previa? Previous surgeries or instrumentations like previous cesarean section, evacuations, myomectomy, then placenta previa, increased parity, increase in your maternal age, and multiple pregnancies. Placenta previa. What are the features? Like patient will have recurrent episodes of painless feeding. Sometimes it can be painful, but most of the time it is a painless feeding. The abdominal findings will be a soft, relaxed uterus. You will not feel any contraction, but the fetal presentation will be abnormal. Either it will be transverse or breech, or if it is cephalic, the head will be high. According to the bleeding, maternal cardiovascular compromise will be there. The fetal condition normally is satisfactory because the blood loss is for the mother. Unless it is severe, then only fetal problems will start. Okay. So painless recurrent bleeding, 1/3 it is happening before 30 weeks, 1/3 from 30 to 35 weeks, and 1/3 after 36 weeks. Usually the first episode is mild, and it can get worse, and it will be with an abnormal liver presentation. Investigation would be with ultrasound. Transvaginal scan, it is safe and more accurate than the abdominal scan. And as I said, leading edge within 2 centimeters for internal os. We consider that as placenta previa. Okay. So what you do if you're suspecting placenta previa, you admit the patient, no examination. Vaginally, you put an IV cannula, you do scan for placental localization, and you do the conservative measures that Dr. Dhaval covered, like fetal lung maturity or whatever is required. One second. All right, so delivery for these patients will be by cesarean section. And once you are doing a scan, try to go either below the placenta, around the placenta, and be aware of the morbidity adherent placenta. And sometimes you might need a cesarean hysterectomy. Can these patients be managed on outpatient? Yes. Those patients who are having no bleeding, they can be managed as outpatient cases. And they should be advised to stay close by to the hospital, and they can come back to the hospital whenever there is a need. Inpatient is for initial 72 hours, and if they are stable, they can be sent home, provided the fetal heart is reactive, and they should be given ambulance numbers 24/7. They should be allowed. They should be advised not to have intercourse and take adequate rest at home. And they should be explained about all the complications, and weekly follow-up should be advised for them. Anytime they start to bleed, you just have to admit them. And if everything is fine, after 34 weeks, better to admit them. Okay, any questions so far from anyone? No questions? Okay, so the third type of vaginal bleeding can be a vasa previa. Vasa previa is the blood vessels, they run from placenta or umbilical cord across the internal os beneath the baby. So whenever you rupture the membrane, the bleeding happens, and it is associated with very high fetal mortality, 50 to 75%. So fetal may rupture this can happen at any time during labor. And even if once you see little bleeding and there is abnormal CTG, always think of this vasa previa, because you have very less time. In that case, you have to deliver the baby immediately. So how you diagnose moderate vaginal bleeding, fetal distress? Vessels may be palpable once you are doing a vaginal examination, or you may have a antenatal diagnosis of these on ultrasound. It is difficult to distinguish from abruption, and you can look for fetal HB test or nucleated RBCs in the shed blood, and the CTG will be abnormal. They can be tachycardia, bradycardia, and if you are not taking action, the baby will die. So it needs urgent delivery, urgent cesarean section if the patient is not fully dilated, and aggressive resuscitation of the baby is required with blood transfusion. Okay, so this was all about the antepartum hemorrhage. Then Dr. Sama, she performed very, very well. So I asked her that what you do once you see a pathological CTG. So you turn the patient into left lateral position. You give her IV fluid. You do the continuous CTG monitoring. And if still the CTG is not improving, then you do a fetal blood sampling. If the fetal blood sampling is more than 7.25, you continue monitoring. If the CTG is still pathological, then you can repeat the fetal blood sampling. And if it is becoming abnormal, then you have to expedite delivery. Okay, then we spoke about the cesarean at full dilatation. I think Dr. Sama was very good. She covered everything in this part. This is a very difficult cesarean, challenging procedure. Then a first stage or non-labeling cesarean section, it carries a very high rate of maternal morbidity. A morbidity is related to a prolonged second stage, and it is directly related to how long the patient is in labor, and if you have any extensions at the uterine angle, and how long you took during surgery. Is there any bladder injury, or these patients are more at risk of having postpartum hemorrhage, pyrexia, infection, there is long stay of the hospital, and all patients. So one thing Dr. Sama, she did not cover was once you are doing a cesarean section at full dilatation, you should inform your consultant and let her be the operation theater or nearby if you need her. So the consultant presence at trial of instrumental delivery or a fully dilated cesarean is important. So you have to mention that thing. Then there is increased risk of neonatal complications in a second stage cesarean section. There can be fetal acidemia, trauma, cephalohematoma, intracranial hemorrhages, some lacerations for the baby, facial nerve palsies. Subsequent neonatal intensive care admissions will be required. The incidence of fetal acidemia is increased in neonates who are delivered by cesarean section after unsuccessful instrumental delivery. So this patient is again high risk of having a fetal acidemia. So as doctor already spoke about this extension, it is a deep, head is deeply engaged in the pelvis. So there is a potential risk factor for maternal and fetal injury. There is more risk of genital trauma and perinatal morbidity, and even increased risk of bleeding, and patient might need hysterectomy later. So incision, this all was covered nicely by Dr. Sama. No problem. I will not go through it because she covered everything. Then 3 ways there are to deliver the baby, either pull or push or the Partum method. Doctor covered all these things, and this fetal pillow with which you can push the baby head from down. Any questions so far? No questions. Okay, so this was the device which doctor was talking about, the fetal disinfecting system, which is a silicone device which is placed in vagina. It is filled with the saline. It elevates the fetal head by about 3 centimeters. And it is still not very commonly used, but it is something which will be beneficial in future. Then complications, doctor already spoke about the extensions, the chances of having bladder injury, ureteric injury. Everything was covered nicely by doctor. All right, postpartum, this all was covered. So now postpartum hemorrhage. Dr. Vidya, very well done. You covered everything. So these are the different definitions of postpartum hemorrhage as per different boards, because now we are doing all the boards in the world. So we have a WHO classification, the ACOG, the RCOG, and the others. So this is I will not go into the details of all these. So whenever you are seeing a patient, either a minor PPH or a major PPH, so minor PPH, you start, the blood loss is between 500 to 1000 ml. The patient is not in shock. So you put a cannula, you take blood for Gruppen screen and full blood count, coagulation, you monitor her vital signs, and you start the crystalloid infusion. This is all the management. Everything was addressed nicely by Dr. Vidya. It can be tone, it can be some tears or trauma, it can be some retained tissue. So how to manage all this, which was nicely covered by doctor. I will not go into the details because she told about everything. So what are the risks once the patient is having bleeding? It can lead to all these problems. So what are major obstetric hemorrhage? Blood loss is more than 1000 ml, and the patient is in a state of clinical shock. So what you do, Dr. Vidya covered everything. You call for help, you call your senior midwife, obstetrician, anesthetist, you alert the hematologist. You don't call the hematologist, you just alert, okay? So no need for the hematologist to come to the labor room or wherever the thing is happening. You just have to alert that you need more blood. The lab and all these people will be informed and alerted. So this all was done nicely by doctor, so I will not go into the details. How the medical treatment will be done, oxytocin, carboprost, misoprostol, everything was done. What all investigations, catheter you need to insert and all, and theater, what all you need to do, balloon tamponade, stepwise ligation, and finally, if nothing is happening, then hysterectomy. Postpartum patient, of course, will be in ICU. There will be all ICU care. Maybe patient will need antibiotic and more replacement of the blood. and then there will be documentation, debrief, ethics, and duty of conduct. So very well done, Dr. Vidya. Everything covered nicely by you. I'm very happy. So tell me if there are any more questions. I'm here to answer you. Either you did not understand anything or you understood everything. So nobody want to ask.
Dr. Uzma, this PPA station obviously will be coming as a structured discussion only.
Yeah.
Okay, and will there be, as I was continuously talking, will there be any break, means whether they will be asking a set of questions, whether I'm missing in between or do I have to stop in between?
No, Vidya, the very interesting part of MRCPI-OSCE is if you know the subject, you will just read and you will talk and talk and talk. Nobody will stop you unless you have not covered anything. Okay, if something you have missed, then once you stop talking, then they will ask you whatever you have missed. And if you know the answer, well and good. If you don't know the answer, then that's it, no problem. So, you know, if you know the subject, you will just be talking. That is it. Nobody asks questions, because in my exam, I noticed that the scenario is written in front of you and you will read and you will start to talk. And you will wait. Maybe all the OSCE stations, if you know the subject, you will finish before like 3-4 minutes is still remaining, and then you will talk of social things with the examiner. This is what I did at least. So it's just your knowledge which is tested in MRCPI. Okay.
Okay, thank you, Dr. Uzma.
Welcome, no problem. Anyone else want to ask anything? No one? Dr. Shagupta, you want to know anything? Dr. Atya? Okay, so I think either I'm very, very clear or I'm not clear at all. So everybody is just sitting silently. No problem, it's fine. So as you know, we will be starting our OSCE course from tomorrow. We still have few places available. So anybody who wants to sit for March or May, they can join us. We will be conducting 6 sessions, and each session we will do 2 long cases and 5 OSCE stations. It will be all from the previous exams. Even the questions will be similar as like exams. So if anybody is interested, they can contact MedExam expert team